Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. In today's episode, we explore the role of rapid syndromic testing in the diagnosis of respiratory tract infections, both upper and lower. I'm joined by Dr. Michael Satlin from Weill Cornell Graduate School of Medical Sciences in New York. To follow along with the slides, please visit the show notes for this episode. Now let's get started.
Welcome, everyone. So our objectives for today are to describe potential benefits of syndromic testing for respiratory tract infections, both upper and lower respiratory tract, how to integrate the results of syndromic testing panel results into patient care, and identifying best practices about how these powerful tests can be used to hopefully improve outcomes for our patients. So first thing we're going to do is talk about what are syndromic panels, what are the different types, what do they detect? We're going to talk about considerations about whether you should be using a respiratory syndromic panel for your patients, how to report and interpret results, what are some of the limitations of these assays, how do they impact patient outcomes, which of course is what we all really care about, and some take-home messages that can help you as you work with your laboratory to implement these tests. Just starting off with the basics, what is a syndromic panel? Usually it's a molecular assay, often multiplex PCR based, but sometimes other methods. But the point is that they can simultaneously detect and identify multiple pathogens that are associated with a given clinical syndrome. So for example, there are syndromic panels for bloodstream infections. We're going to talk today about the ones for respiratory tract infections, but they have panels for gastrointestinal infections, joint infections, CNS infections. And some of these panels can also detect antimicrobial resistance genes that are carried by common bacterial pathogens. So sometimes they can tell you not only what's there, but also give you some information about antimicrobial resistance of whatever pathogen might be there. Many of these molecular syndromic panels are done in laboratories. However, it's important to know that some of these panels are actually point of care tests. And by point of care, I mean that these are tests that can be run at the bedside to the patient. For example, they could be run at an urgent care center or within a doctor's office, as opposed to having to send the specimen to a true laboratory to run the test. And for example, this is the BioFire Spotfire system. And so this is a true point of care test for upper respiratory tract infections. And the Spotfire system can detect many of the different viruses that cause upper respiratory tract infections. And there's a different panel for viruses and bacteria that can cause sore throat. But it's very exciting that some of these syndromic panels are now moving to point of care. There are many laboratory-based upper respiratory tract infection syndromic panels, but essentially most of them will identify the common causes of upper respiratory tract infections. There are a plethora of these tests. They all work slightly differently, but pretty incredible that all these different assays can cover all these different pathogens with a single test. Now, there are also lower respiratory tract infection panels, and probably the one that's used most commonly is the BioFire Film Array Pneumonia panel. This is quite popular because clinical microbiology laboratories often use the same platform for other syndromic panels like bloodstream infection, gastrointestinal infections, etc. And so because the platform already exists, it's sort of much simpler to be able to incorporate this panel. And so this panel can detect many of the bacterial causes of pneumonia. So typically when we're talking about lower respiratory tract infections, we're talking about patients with pneumonia and trying to figure out what the pathogen is. And for many of these bacteria, it not only detects what's there, but it also provides a semi-quantitative result, which we'll get into in a minute. It detects common atypical bacteria such as Legionella and Mycoplasma. And importantly, it detects a number of antibiotic resistance genes, whether they're present or absent, and we'll talk about that. And importantly, it not only detects all those bacteria and resistance genes, but it also detects most of the common viruses that can also cause pneumonia, such as influenza, RSV, etc. There's another panel which isn't used quite as frequently, but it has some differences. It's the Univero assay. And so similar to the BioFire Film Array Pneumonia panel, it detects many bacteria, although there are some differences. For example, the Univero assay will detect certain organisms that are not on the BioFire Film Array Pneumonia panel. And I think one of the big ones to notice is Stenotrophomonas multifida. That's an important one, of course, because it's resistant to carbapenems and most beta-lactam agents. Differently, this one provides you a qualitative result, so not a semi-quantitative result. It detects the same atypical bacteria. It detects antibiotic resistance genes, including resistance to genes that confer resistance to carbapenems and Acinetobacter, such as OXA23. And also importantly, it detects an important fungus, Pneumocystis jirovecii, which of course is an important cause of pneumonia in immunocompromised patients. So some differences here. So one of the first things that, we should be thinking about is who should we be sending these syndromic panels are? They're often expensive, so they can cost anywhere between $100 to $200. So we want to think about who these panels are most appropriate for. And there's certain criteria that I think about. One is a patient immunocompromised? So for immunocompromised patients, it may be very important to be able to distinguish RSV from influenza. Many of these patients are getting treated with immunosuppressive therapies, and having an infection with one virus or another may have implications for the timing of their treatments. Moreover, in an immunocompromised patient, you might be much more likely to actually treat some of these respiratory viruses. For example, you may want to give ribavirin if they have an RSV pneumonia, or you may want to give oseltamivir if they have influenza, whereas you don't always need to do that in non-immunocompromised patients. So is the patient critically ill? So how sick is the patient? The sicker the patient is, for example, somebody going to an ICU, you may be more likely to, or knowing what type of virus or what type of bacteria they have could be more useful to you. It's important to be able to rule out other things. So as a general rule, where somebody who's completely healthy, particularly if they're not immunocompromised, maybe it's not so important to know whether they have parainfluenza virus or RSV. Are the results going to influence your patient's care or outcomes? So for example, with the pneumonia panel, is your patient at risk of having an infection due to an antibiotic-resistant organism like Pseudomonas or Acinetobacter, and if they are, then maybe this panel would be quite helpful because those may not be organisms that we would empirically treat for community-acquired pneumonia. It's also important to think about where the patient is going after the test is done. Are they going to an immunocompromised ward? If so, it's really important to know whether that patient has, say, RSV infection, because you want to be able to either cohort that patient with somebody else who has RSV or make sure that they have their own room. So there can be important infection control and isolation benefits to knowing exactly what your patient is carrying. So I'm going to give an example. Sometimes these syndromic panels can have so many targets, and it can be challenging to know how to report the results. I'll give an example here of how we report the results. We like to report all of the different targets that are detected by the assay and then say whether it was detected or not. And we do this because we think it's important for clinical teams to know not only what was detected, but also what wasn't detected. So for example, in this patient, we can see that they had Acinetobacter baumannii complex detected and had it detected at greater than or equal to 10 to the 7th. And they also had rhinovirus detected. But you can see here all the things that were not detected. And so we think reporting both is quite helpful. So this is how we do it. So how can, for example, the lower respiratory tract infection panel guide or change your antimicrobial therapy? One way is that it could detect resistance genes that may change your empirical therapy. So probably the most common example is that you detect the MEK-A gene, okay? And that confers methicillin resistance in Staph aureus. So if you have this MEK-A with MREJ and you have a Staph aureus detected, you know that that's an MRSA. And of course, this is important because for a patient who previously was not started on an anti-MRSA drug like vancomycin or linezolid, that could be added to their care. And you would get this information much more quickly than waiting for culture and antimicrobial susceptibility testing. For gram-negative bacteria, you can detect one of the main carbopentamases. You can see here KPC or NDM or VIM or OXA48, and each of these has its own type of therapy. But for example, if we found that our patient had KPC and Klebsiella in their Fillmore pneumonia panel, we could start them on ceftazidime maybe Bactam or meropenem Bactam without having to wait for culture and susceptibility testing. And typically, unless your patient has been infected with one of those organisms before, this isn't something that you'd start empirically. Another big one is this CTXM gene. So this is the most common ESBL or extended spectrum beta lactamase. And if you saw this result with an E. coli or Klebsiella, and your patient was started, say, on cefepime for empirical therapy for their pneumonia, you would want to broaden that patient to carbapenems, which are the drugs of choice to treat infections due to organisms that produce this enzyme. Importantly, this panel can not only be used to guide escalation of antimicrobial therapy, but it can also be used for de-escalation. So how might this work? Probably the most common example is if you don't detect the genes that confer methicillin resistance in Staph aureus, MEK-A, MREJ, you can stop vancomycin if it was started empirically. If you don't detect Pseudomonas or other non-fermenters like Acinetobacter, you potentially could narrow away from anti-Pseudomonal beta-lactams, because if they don't have Pseudomonas molecularly on their BAL specimen, for example, maybe you don't need to cover that organism, even if you normally would cover that empirically. If you detect Klebsiella or E. coli with no resistance genes, you can be pretty comfortable that they don't have an ESBL producing organism or a carbapenemase producing organism, and you could potentially switch whatever you started empirically to a drug like ceftriaxone. If you detect pneumococcus or H. flu, you don't need, say, piptazo or cefepime, again, could switch to ceftriaxone. If you detect atypical bacteria like Legionella, you can get that patient quickly started on a macrolide or a fluoroquinolone. And of course, if you only detect viruses or you don't detect viruses or bacteria, there may be situations where you could potentially just stop antibiotics. However, it's important to know that this panel doesn't detect all bacteria or all viruses. So that's really a clinical decision that you'd have to make, but this gives you a nice piece of information. Now, another important thing is that this panel can be by detecting organisms that are common causes of pneumonia, like Pseudomonas and Acinetobacter. These organisms are often frequently resistant to empirical antibiotics that you might have started for your patient. And essentially, no matter which antibiotic you pick for your patient, about a quarter of the time, the organism, if it's Pseudomonas, is not going to be susceptible to whatever you picked. And that may be fine for some patients, but if you had a critically ill patient or a patient with sepsis, maybe you don't want to rely on having a 75% chance of being right. So there may be some situations where just by detecting Pseudomonas aeruginosa, it might lead to modification of your empirical therapy. Maybe you add a fluoroquinolone or an aminoglycoside to your beta-lactam. Maybe based on your local epidemiology, you switch to a drug like ceftolozane tazobactam, which has expanded coverage for Pseudomonas. If you have a critically ill patient and you detect Acinetobacter on this Filmarae pneumonia panel, and you start them empirically on a carbapenem, 41% of the time you're going to be wrong, meaning the organism is going to be not susceptible to the carbapenem. So again, might make you change your antibiotic therapy. Importantly, it's really important to use your local antibiogram. So, all infectious diseases practitioners should know in their own center of my Pseudomonas aeruginosa or of my Acinetobacter baumannii in or outside of the ICUs, what percent of those organisms are susceptible to different agents. So I told you before that the lower respiratory tract infection panel, the Filmarae pneumonia panel, gives semi-quantitative results for most of the bacteria. And so this is the way they do it. They do it in bins. So the options are the organisms not detected, there's 10 to the fourth copies per ml, 10 to the fifth, 10 to the sixth, or greater than or equal to 10 to the seventh. So these are semi-quantitative bins. And importantly, these do not necessarily correlate with colony forming units per ml. So you're probably used to in your BAL cultures, that's how you get those results, greater than 10,000 CFUs per ml, for example. This is copies of DNA per ml. That's important because it doesn't always necessarily correlate with CFUs per ml. Moreover, the semi-quantitative panels, you may get a lot of positive results on the BioFire Filmarae pneumonia panel, and then you don't grow the organism in culture. And so this can create a clinical dilemma that you should be aware of. And so, for example, this is a study, this is actually data that combined the data that were submitted for FDA approval for this assay. And of all the specimens where you got a given result on the pneumonia panel, how often did you grow 10 to the fourth CFU per ml of the bacteria in the culture? And so if you had less than 10 to the fourth or not detected, essentially you never grew that organism at 10 to the fourth CFU per ml in culture. And even if you detected 10 to the fourth copies per ml of the pathogen, only 3% of the time did you grow 10 to the fourth CFUs per ml of that pathogen in culture. It only goes up to 11% at 10 to the fifth. So remember, the vast majority of patients, when you get 10 to the fourth and 10 to the fifth, you're actually not going to grow that organism in culture, at least at the quantitative threshold that we usually use to correlate with pneumonia. Even at 10 to the sixth, only 22%. It isn't really until you get to greater than equal 10 to the seventh copies per ml on the pneumonia panel that more than half your patients are actually going to grow that organism at the quantitative threshold that we usually use in culture. So it's very important to remember this. And so implementation of this test is going to create some clinical conundrums for you as a clinician and the clinical team about how to interpret some of these results. But it's important to expect this. Also, as I said earlier, these syndromic panels, it's amazing all the different pathogens they cover, but they don't cover everything. So, for example, some of the quote holes for bacteria for the Filmarae pneumonia panel, I would say Stenotrophomonas is a big one. a common carbapenem-resistant pathogen, it is detected by the Univero assay. I'll say nocardia is another one that commonly comes up. It's not detected in either assay. For fungi, the PCP is not detected by the Filmarae pneumonia panel. It is detected by the Univero assay. And these panels, none of them are really designed for other types of like mold pneumonias or endemic fungi that commonly cause infection in immunocompromised patients. So we're not picking up Aspergillus or Mucor, for example. Viruses, I would say the two main holes in these panels, they don't detect, at least in their current version, SARS-CoV-2. So obviously that can be important. And they don't detect CMV. So having a negative assay on either of these panels doesn't rule out infections due to those organisms. And in fact, if you look at a recent French multicenter study of ICU patients, they found that 21% of the bacteria that they isolated in BAL cultures were not detected by their Filmarae pneumonia panel, just to show. So when you get negative results, you do have to take this in context. And for that reason, it's really important that these syndromic panels are wonderful rapid tests, but they're really an adjunct to culture and antimicrobial susceptibility testing. They don't replace those. So why culture? As I just showed you, it's really important to be able to identify organisms in culture that aren't on the panel, including fungi. And I think there's also value in knowing that there's live replicating organism in there and not just DNA. And importantly, although the resistance genes are nice that are included in these assays, they're not a replacement for susceptibility testing of an isolate that you recover in culture. This is particularly important for hospital-acquired pneumonia, where resistance is quite common. It's really important for Pseudomonas aeruginosa. So all of the genetic targets that predict resistance on the panel, the carbapenemases, the CTXM, these are really very uncommon in U.S. isolates, and they provide very little predictive value of resistance in Pseudomonas. Similarly, for Acinetobacter baumannii, although the Univero panel has its carbapenemase oxid-23, the Filmarae pneumonia panel doesn't, okay? So if you don't get culture and susceptibility testing, you're really sort of in the dark about which antibiotics you should be choosing for your patients without susceptibility testing. There's other things we do that are also really important from respiratory specimens, including the gram stain. This is really the original rapid diagnostic test. Direct from the specimen, you can tell what types of organisms are in there, like gram-positive coccidin clusters, for example, how much is in there. And also, and this is really important for sputum samples, it's really important to know whether the respiratory specimen is mouth bacteria from spit or is it a true lower respiratory tract sample. So as we know, these specimens should have few squamous cells and many white blood cells. And if they have a lot of squamous cells and don't really have white blood cells, that can be indicative of contamination. Cell count, also a really important test from BAL fluid. So there's consistent data out there that if you have BAL fluid with fewer than 50% neutrophils, assuming the patient isn't neutropenic per se, that's a really good rule-out test for bacterial pneumonia in ICU patients. So let's talk about the impact of these panels. How do these panels actually change care for patients? And so this is a trial that was done in hospitalized patients. It was a single center study. It was open label. And what it did is it randomized at the laboratory level patients to or workup of respiratory tract specimens to the Filmarae pneumonia panel plus culture and susceptibility testing. That was the intervention group versus just culture and susceptibility testing alone. That was the control group. And it did this in almost 1,200 hospitalized adults with suspected pneumonia. It did it using sputum, tracheal aspirates, or BALs. And other tests, like maybe NERA swabs for MRSA PCR or urine Legionella antigen, was all at the discretion of the clinical team. And there was antimicrobial stewardship that was there, and they received results for both arms from 8 a.m. to 5 p.m. Monday to Friday, and they had standardized recommendations based on the results. And the primary outcome for this study was time to first antibiotic modification, so either escalation or de-escalation within 96 hours. And so let's look at pathogen detection rates. And you can see for organisms that are common causes of hospital-acquired pneumonia, like Staph aureus, Pseudomonas, E. coli, Klebsiella pneumonia, that actually the detection rate in the Filmarae pneumonia panel was quite similar to the detection rate using culture. But where the Filmarae pneumonia panel really increase your yield is with some of your community-acquired pathogens, many of which are more fastidious, like, for example, strep pneumonia or pneumococcus, Haemophilus influenza. And of course, the other big improvement with the lower respiratory tract infection panel, the pneumonia panel, is speed, where it took, 29 to 42 hours to identify a pathogen in culture here. Here with a pneumonia panel, you're detecting that within 2 hours. Now, what did it lead to? That's nice about detecting more organisms or detecting them faster, but how did that translate to outcomes for patients in regards to antibiotic prescribing? And what you can see here is that for gram-positive bacteria that were detected by the panel, that led to faster escalation and de-escalation. And primarily that's related to vancomycin for MRSA coverage. For gram-negative enteric bacteria, it did lead to faster escalation when you had an antibiotic-resistant organism detected, but not for de-escalation. Unfortunately, although the antimicrobial prescribing was modified, it didn't lead to other clinical outcomes that patients really care about, like mortality and length of stay. This is another study that was done using the Filmare pneumonia panel for patients presenting with community-acquired pneumonia to the emergency department. It was a single center study. It was randomized. It had 374 patients, and their primary outcome here was pathogen-directed treatment based on the microbiologic result. And when you use this intervention with the pneumonia panel, you more frequently got patients on a true treatment of a pathogen that was detected. However, that didn't necessarily mean that these patients actually had improved clinical outcomes. So, what about the clinical impact of upper respiratory tract infection syndromic panels? This is a meta analysis of 25 studies evaluating the use of this panel in both children and adults. And what it found is that use of upper respiratory tract infection panels was associated with a reduction in antibiotic therapy, improved antiviral use, and more accurate implementation of infection control measures. Now, as far as the antibiotic therapy, the impact of this test was greatest in people who had a low likelihood of a bacterial infection. So that's where the addition of this information that detected, say, a virus and no bacteria made clinicians feel more confident in not using antibiotics. Another important feature is that the quicker these panels gave results, the more likely they were to lead to a decrease in antibiotic use. This is one particular randomized trial, and I think it highlights one important point. It was done as a point of care syndromic test versus standard test, and 360 patients who are presenting with an acute respiratory tract infection to urgent care. And what they found was that although, antibiotic utilization didn't differ in this study, the patients were more satisfied with knowing what they were infected with. So, for example, they returned to activities of daily life sooner. They were confident in knowing exactly what was causing their infectious diseases issue. And so sometimes I think we overlook the importance to patients knowing what they have. Just one more randomized trial to point about. This is a study of children who were presenting with influenza-like illness to the ED. It did not find any decrease in antibiotic prescribing. Other randomized trials that have been done in adults have also not necessarily shown improvements in antibiotic prescribing. So I think a lot of this shows how when you do studies that incorporate all comers to the emergency room, not all of them are necessarily going to benefit from a syndromic panel for an upper respiratory tract infection. However, there still may be patients who do benefit, such as immunocompromised patients or patients who are critically ill. So just some take-home points to wrap it up here about respiratory syndromic panels. They detect the DNA or RNA of many common, both community-acquired and hospital-associated bacteria, including atypicals, viruses, key antibiotic resistance genes. And then you get these results within a couple of hours, as opposed to culture results, which will come days later. Upper respiratory tract point of care panels can be used to improve patient satisfaction, but I think their influence on other outcomes is still mixed. And those most likely to benefit from upper respiratory tract infection panels are those who are immunocompromised or who have severe illness. And just remember, although these panels are great, we still need to especially for lower respiratory tract infections, it's still really important to do things like culture, susceptibility testing, gram stains, and BAL cell count fluids. And with that, I hope you enjoyed this and learned a lot. I think these respiratory tract syndromic panels are really beneficial for patients, and we need to continue to push the envelope to understand how to best use them. Thank you.
Thank you, Dr. Satlin, and many thanks to our listeners for joining in. To view the full program on rapid diagnostic testing and other infectious diseases, click on the link in the show notes. And to get access to all of our new podcasts, you can subscribe to the CCO Infectious Disease podcast on your favorite player. Thanks so much, and we'll see you on the next webinar soon.